done his DM from MS Ramaya Hospital, Bangalore, and he has done his DM from Nizam's Hospital, sir. Rajesh sir, I mean, Dr. Kamar sir, I mean, he's the brainchild of this particular molecule. I was done everything I can say, I mean, as of today. I mean, sir has got a good experience about Mycidac-C. I mean, it was the first Indian immunomodulator, I can say, sir, which we have launched. So that's how it has been. And any queries, sir, Dr. Kamar sir will be definitely supporting. And Dr. Amit sir will take through the presentation completely. So if anything, I mean, you can just let us know.
Okay.
Yeah, that sounds great. Yeah, you can go ahead.
Thanks, Somsekhar. So, sir, as I told you, like this product is actually been known as Mycidac-C, which is the brand name here, and it is containing the heat kill microW, like which is the sister species of microbial tuberculosis or tuberculosis bacteria, which is having a strong immunomodulator activity. So, talking about the molecule here, this molecule is available with us since some time, and over a period of this time we have done number of studies here upon the molecule. Like in the case of, we started with the development in the case of leprosy, followed by tuberculosis. Now at the moment it is being utilized for a number of malignancies here, and some other diseases which I'm going to be sharing here. So let us see this video.
Life is beautiful. The world we
I hope the sound is audible.
live in,
Yes, I can.
Yes, sir.
the air we breathe, the happiness we share. Imagine it all coming to an end. Imagine the cruel hands of a deadly killer snatching it all away. A killer named cancer. Cancer, the dreaded C word. Lung cancer, the most dreaded of them all. Lung cancer is the major cause of cancer-related deaths worldwide. More than 100,000 people are diagnosed with lung cancer every month. Much more than any other type of cancer. How does cancer develop? Immune evasion leads to cancer development and progression. Increased immunosuppressive mechanism leads to decreased immunosurveillance. Current therapy. All effective therapies improve immune function. Chemotherapy decreases immune suppression, increases immune activation, and is synergistic to immune therapy. Desmocolin 3, DSC3, is diagnostic of squamous non-small cell lung cancer. Chemotherapy converts DSC3 negative to DSC3 positive cells. It is also expressed in other cancers like melanoma, colorectal cancer, besides many others. The emerging treatment, Mycidac-C. Mycidac-C is active immune therapy targeting DSC3 expressing cancer. Mycidac-C activates immune cells and expresses DSC3 on their surface. Mycidac-C reduces immunosuppression by its effect on immunosuppressive cells and cytokines. It preferentially kills DSC3 expressing cancer cells. Mycidac-C provides synergy to chemotherapy. All this backed by solid research and innovation. Randomized controlled clinical trials have been conducted wherein Mycidac-C is added to standard chemotherapy to evaluate its safety and efficacy. Research studies have proven that addition of Mycidac-C does not add to toxicity. Addition of Mycidac-C improves response rate. Addition of Mycidac-C improves overall survival probability by 28.2%. Improvement in survival in squamous non-small cell lung cancer (NSCLC) is 43.5%. This is significantly better than most other therapies. The future. Mycidac-C, a game changer in the treatment of lung cancer. Cadila Pharmaceuticals' extensive research relating to the treatment of lung cancer has brought a smile to many a face. All this would not be possible but for the vision, persistence and foresight of Shri I.A. Modi. His thinking was very clear. Anything that can add to a moment of life and make it more meaningful is definitely worth the effort. Mycidac-C offers that hope for life. Mycidac-C
So coming to the presentation here, this is the presentation on the topic of immunotherapy in the cancer. So this is the immune mechanism in the cancer. We know at the level of tumor microenvironment, uh, uh, there is an immunosuppression is there because of the loss of the uh, these T cells. So as we see, there is a decrease in the immunostimulatory cells is there, and these T cells are not able to recognize the tumor cells because of the lack of positive recognition over their surfaces. So same being shown here, there's immunosuppression negative cells, negative signals are there, and by which the tumor is able to grow. And because of the presence of these markers here, the T cells are not able to recognize them. So to talk further here, what has been done here in the laboratories, the effect of Mycidac-C immunization on the immune cells and the effector function. So as you see here, Mycidac-C induces the expression of the desmocolin 3 on the surface of the immune cells. So as you see here on the left side of the picture here, giving the single injection will be inducing the desmocolin 3 on the expression on the surface of T cells up to extent, and giving Mycidac-C multiple injections will be creating the more levels of the desmocolin 3 on the surface of T cells. And as been shown upon the right side of the picture, there is a more killing, more cytotoxic effect has been seen by these T cells who do express the desmocolin 3, and there is an enhanced killing is there. And because of the desmocolin 3, there is a more cytotoxic effect is there. And those cells who do not have the or who have the negative desmocolin 3 on their surface, there is a lesser cytotoxicity is there. So to talk further here, chemotherapy and the desmocolin 3. So these tumor cells, they do express the desmocolin 3 on their surfaces because of the exposure of the chemotherapy. And this is true even with the subtherapeutic doses. Like as you see here, with the levels of cisplatin, paclitaxel, doxorubicin, gemcitabine, there is a these tumor cells they do express a desmocolin 3 on their surfaces. So desmocolin 3 negative cells, which are initially negative, they do express the desmocolin 3 following the chemotherapy, even with the 1/10 or subtherapeutic doses. So Mycidac-C induces the expression of desmocolin 3 on the surface of T cells, and desmocolin 3 expressing immune cells, they do get the desmocolin expressing cancer cells. And desmocolin 3 is also the marker for the squamous variety of the non-small cell lung cancer, which I'll be showing here. Since multiple number of published literature have been shown that squamous variety is having the more expression of the desmocolin 3 on the surfaces. Squamous variety is having the more expression of desmocolin 3 on the surfaces in comparison to the adenocarcinoma and the last cell carcinoma, which I'll be showing here. Further, desmocolin 3 negative cancer cells express desmocolin 3 following the chemotherapy, which I've showed here, even with the subtherapeutic doses. So, talking about the some details about the molecule here, it is an innovative product from Cadila Pharmaceuticals. It is having a strong immunomodulator activity. And talking about the components here, it is available in the pre-filled syringe with a volume of 0.2 ml, and each 0.1 ml is containing the micron W heat kill with a strength of 0.5 multiplied by the 10 to the power 9 bacilli. And here sodium chloride is being added as an excipient, and thiomycin has been added as a preservative here in a very low quantities. Further, these are the sites of recommendation, like intradermal sites are the recommended here, and followed by the suprascapular region around the umbilicus and inner part of the thigh. So here the injection is being recommended by the intradermal route. So to talk further here, this slide shows the detection of the desmocolin 3 expression on the tumor cells, which shows the immunohistochemistry using the commercially available antibody stain. So this I was talking to you earlier. This slide shows the compilation of those published literature which talks about the desmocolin 3 expression in the various histological types of NSCLC, including squamous variety. So when we see here like Ward et al., Kim et al., Tetsu Suta, Monica et al., Ricky. So if we compile all of this data, it says uh, in about 86.25% of these cases, squamous histological type, they will be having the expression of desmocolin 3, which is more in comparison to adenocarcinoma, uh, where it has been shown like only 0.45% of these histological type will be having the expression of desmocolin 3. When I talk about the last cell, the level is 4, here it is 11.2%. So it proves that desmocolin 3 is the marker for the squamous non-small cell lung cancer. To talk further here, this is the clinical trial data on Mycidac-C in the patients of non-small cell lung cancer metastatic cases. So this was the initial pilot study, open label randomized controlled clinical trial of desmocolin 3 targeted toll-like receptor agonist Mycidac-C in the advanced non-small cell lung cancer cases. So post-randomization in the control arm, only chemotherapy was used as platinum and cisplatin with the etoposide 6 cycles. So in the study arm, along with the chemotherapy, Mycidac-C as an immunomotor was added here with a dose of 0.1 ml every fortnightly for the period of 6 months. So for 6 months, the therapy continued. Talking about the baseline characteristics of these individuals, they were both of the arms, they were similar with respect to age of the patient, sex, both gender population was be the part of the study. And talking upon the Karnofsky score, again, they were similar in nature. And stage of the disorder, all of these patients were actually being suffering from the stage 3B or either the stage 4 disorder. Talking about this further, this was the outcome of this clinical trial. Talking about the response here, so with the immunomodulator arm, Mycidac-C, here it was 38%, which was 11% better in comparison to the platinum arm, where it was 27% only. Talking about the progressive disease, here it was found to be 19% with the immunomodulator arm versus 27% with the chemotherapy arm. So progression of disorder was lesser in the Mycidac-C arm versus the chemotherapy arm. And one case of complete response was seen in the treatment arm, but none in the case of chemotherapy arm. To talk further here, uh, upon the adverse events, both of the arms, here the Mycidac-C arm was actually been having the lesser number of side effects in comparison to the chemotherapy arm. Uh, in respect to pneumonia, chest pain, asthenia, vomiting, platelet count, lowering anemia, leukopenia, and the neutropenia. To talk further here, this is the data upon the approval clinical trial of Mycidac-C. It was open label, randomized controlled clinical trial on desmocolin targeting toll-like receptor agonist Mycidac-C in the combination with platinum containing doublet, paclitaxel is cisplatin versus only chemotherapeutics. paclitaxel plus cisplatin in the advanced non-small cell lung cancer cases. So post randomization, the one arm was being given with the chemotherapy with the paclitaxel plus cisplatin with 175 milligram per square meter body surface area, and cisplatin with 100 milligram per square meter body surface area, and each 21-day cycle. And in the study arm, along with the platinum content doublet, the Mycidac-C immunomodulator was added here. So therapy was initiated with a 0.2 ml of injection 7 days prior to the chemotherapy, and on 8th day, 0.1 ml was repeated, and on 15th day, another injection was repeated. So for first chemotherapeutic cycles, the 3 injections were used, and for subsequent cycles, only 2 injections were used, like 8th and 15th day. So for 4 chemotherapeutic cycles, 9 injections were used here, and post that, 1 injection was given every month. So statistical analysis one done who in the patient who received the 4 cycles of chemotherapy as per the protocol in both of the arms, and overall survival properties and the progression-free survival was being analyzed, and safety benefit has been noted in the terms of percentage, proportion, and serious and the severe adverse reactions. So eligibility was same here. All these patients were actually been suffering from the either the stage 3B or the stage 4 non-small cell lung cancer, and patient characteristics were 18 or 18 plus, and performance status was ECOG 0 to 1. Life expectancy was 24 weeks or more than that, and hematological parameters were absolute neutrophil count was 1500 or more than that. Platelet count was 1 lakh or more than that, and hemoglobin levels were 9 or 9 plus. And hepatic functions were as per the standards, and uh, real function was creatinine level was lesser than 1.5, and pregnancy was excluded, and informed consent was taken from every patient here. So with respect to demographic characteristics, all these patients were similar with respect to age, gender, ECOG criteria, stage 3B or stage 4 disorder. Uh, Apart from that, the histological in both of the arms, all histological variety of patients they were included, like adenocarcinoma, squamous variety, others as well as the large cell uh, non-small cell lung cancer were recruited for the study. And to talk further here, death was seen lesser with the Mycidac-C, like 19 patients here, and versus the in the control arm, where it was more number of tests they were seen here. And talking upon this further, and this was the outcome of this clinical study. When I talk about overall response, which comprised of complete plus partial here, it was having the 10% better advantage versus the platinum containing doublet arm. So here it was seen to be 47% versus the chemotherapy arm. There it was only 37%. Talking about the prostate disease, here it was 13% with the immunomodulator arm 11%, which was 5% better versus the chemotherapy arm. So 3 cases of the complete response were seen with the Mycidac-C arm, immunomodulator arm, but none in the platinum containing doublet arm. So Mycidac-C improves the response rate. Addition of the Mycidac-C improves the response rate. So this is a Kaplan-Meier curve of progression-free survival in the patient who actually completed the 4 cycles of the chemotherapy. Talking upon the progression-free survival found to be 96 days better in the Mycidac-C arm versus the platinum containing doublet arm, and the hazard ratio found to be 0.43 in these cases. This is the graph upon the curve upon the for the overall survival in the patients who complete the 4 cycles of chemotherapy. Here, the mean survival time was found to be 298 days versus the control arm, where it was 233 days. So 66 days advantage was seen with the immunomodulator arm, and the hazard ratio was 0.64 here. Talking about the overall survival in the patients who complete the 4 cycles of the chemotherapy in the histological variety of squamous. So this was the best response, which best output was seen in the mean. Talking about the mean survival time here, it was 364 days with the Mycidac-C arm, which was 110 days better with the control arm. There it was seen to be 254 days, and the hazard ratio was found to be 0.4 here, 0.40 here. Talking about this further upon the adverse reactions toxicities here, talking about the hematological toxicities, both of the arms were seemed to be having the similar in nature in the terms of adverse reactions. like anemia, leukopenia, neutropenia. And talking about the non-hematological side effects, dyspnea was found to be lesser with the Mycidac-C arm, and diarrhea was found to be more with Mycidac-C arm, and nausea, vomiting were seen in the control arm, but none in the immunomodulator arm. Fatigue was found to be better more with the Mycidac-C arm. So to conclude here, Mycidac-C immunomodulator Mycidac-C is synergistic to the platinum betadine doublet. It improves the progression-free survival with a hazard ratio of 0.43, and it also improves the overall survival. And for all these cases, hazard ratio was found to be 0.64. And in the cases of squamous non-small cell lung cancer, hazard ratio was found to be 0.40. And the therapy has not been associated with any kind of systemic side effects, though some cases of local side injection side reactions were found. So this is true in the patients who complete the 4 cycles of chemotherapy. And this approval clinical trial was published in Annals of Oncology by cumulative efforts of Dr. Chandra Pilani and Dr. Kamal. So to talk further here, other tumors they also do express the desmoplanthry, where some clinical studies are already been completed and some are under the process of recruitment. So sooner or later we are going to be having their approval. So to talk upon the bladder cancer here, the study was done upon the superficial bladder cancer, and as we know, the BCG is said to be standard therapy recommended there. So rather than giving the intravesical injection, it is found to be here the intradermal injection of Mycidac-C has been found to be same results versus the giving the intravesical administration of Mycidac-C. So some study has been done upon the ovarian cancer, colorectal cancer, malignant melanoma, meningioma, as well as in the head and neck tumors. So to talk further here, this is the another published study in the patients of locally advanced head and neck tumors. So it is a comparative evaluation of Mycidac-C vaccine versus the immunotherapy plus concurrent chemoradiation versus the concurrent chemoradiation alone in the locally advanced head and neck cancer. So this study on the Indian locally advanced head and neck squamous cell carcinoma patients says the use of weekly micro-W vaccine plus weekly cisplatin is safe, and concurrent chemoradiation therapy plus Mycidac-C micro-W may be superior to the concurrent chemoradiation alone in the terms of better response rate, higher local regional disease with the lesser toxicities. So this was another one which is also been published, and which states immunotherapy may be useful as an adjuvant therapy in the head and neck cancer patients receiving the chemoradiation for better clinical response, reduction in the side effects, and improvement in the quality of life. So this I was talking to you earlier on the recurrent and unresponsive non-muscle invasive bladder cancer. So 20 with the non-invasive bladder cancer received the intradouble kidneys of 05, which was the earlier treatment of micro-W. Recurrent free survival at 15 and 30th months was 35% in career patients. The median recurrence-free survival was also better with the BCG unresponsive compared to the BCG recurrent group, and DSC3 expression was present in 68.8% of patients. Tumor infiltrating lymphocyte and recurrent free survival beyond 30 months was seen 2.3 times and 2.8 times more often than DSC3 expressing non-muscle invasive bladder cancer. So I would like to close my talk here and would like to request you to raise questions here. Dr. Rajesh,
Yeah, yeah.
yeah, I'm done. Yeah, I'm done. Yeah.
Thank you for that wonderful presentation. And you are telling that it is having a better role in squamous cell carcinomas, but the approval is for any type of non-small cell lung carcinoma, right?
So, I mean, it is between the two. Say, if you have to select, currently we have multiple options for adenocarcinoma.
Yes.
But you have limited options for squamous cell carcinoma.
Okay.
What we have seen is compared to the other therapies, this gives best result in squamous but that does not mean it does not improve the survival and PFS and response rate in adeno. So it works both, but the results are better in squamous, and probably the results are better in squamous because squamous cell carcinoma naturally express desmocollin 3, while in adenocarcinoma, chemotherapy induces desmocollin 3.
Okay, okay. And what about the skin side effects or toxic effects? Is there any necrosis of the skin?
Yeah, so like BCG, whenever
Right.
you give this product, like BCG, local site reactions are bound to happen, and with multiple injections, they are likely to happen. So what we recommend is that you administer this drug as far as possible from the first drug. Okay, so first injection, second injection. So there are two options. One is you rotate the site, so give it over the arms, deltoids on both the arms, then give it over the around umbilicus, around thigh, and keep rotating, and make sure that two subsequent injections are as far apart as possible, minimum 1 inch. This will reduce the local site reactions. Now, these local site reactions are self-limiting. It does not require any special treatment because it is a manifestation of improved immune response, and this response is maximal at the site of injection because these injections are given intradermal, so it stays there for a longer time. But if you don't want that, then there is option that you can use this intravenous, because so many doctors find it difficult to give intradermal because you depend on somebody supportive staff, and they may not give it properly. So if it is not given properly, then there's a terrific side effects. If it is given properly, there will be local side reactions which will vary from individual to individual, and with the more number of injections, it is likely to happen. So it's not that it will not happen, but to avoid it, if you give intravenous, which is easy to administer for your staff. So if you want to give intravenous, since it is a biological material, you prime it with 1 or 2 cc of dexamethasone 1 hour before, and then give the full dose intravenous slowly over minimum 5 minutes. And this can be diluted in saline easily. So you can dilute as high as 100 ml, 200 ml, 500 ml. This will take care of the local site reaction and ease of administration, but the efficacy will remain the same.
And during the post-marketing surveillance, any side effect of what to say, some side effects that were not seen in the trial?
No.
Because
So I mean, so all the side effects which are seen were seen in the trial.
Okay.
And they are mainly local site reactions. So other side effects are either same or not added. Only side effect which was not seen in the lung cancer, which was seen in the bladder cancer, was that around 2 to 3% of the people develop fever when it was given, but then it subsides on its own and it does not need any special treatment. But other side effects are practically identical, as if nothing has been added to the treatment.
Right.
And when you give intravenous preceded by dexamethasone, none of the side effects are added.
Right. Any complete responses that you have noticed during the post-marketing surveillance? Any doctors?
Amit,
yeah.
Amit, say he will describe a case with a monotherapy without chemotherapy, complete response.
Right.
Amit, your turn now.
Yeah, thank you so much, sir. Sir, there's a case was there who was having the age of 65 years, and that person was suffering from the metastatic non-small cell lung cancer. And what doctor did, doctor initiated the paclitaxel and nab-paclitaxel, and along with that, he started with the cisplatin to the patient. And that person could not tolerate these chemotherapeutics. So ultimately, doctor need to stop them. So he came to the oncologist in the month of, if I recall correctly, in the month of April 2020. And since he was not able to tolerate any chemotherapy, so what doctor did, he kept the patient upon the intradermal injection of Mycidac-C. So that was the only therapy was given to him. And during that point of time, he was completely, under the stage 4. and that was the only therapy which was continued to him. And 2 months earlier, again the CT was done, and other parameters being noted here, and dramatically everything was completely disappeared into that patient. So you asked like complete response. So that was the recent example of complete response that we saw. It. So doctors was very much uh, you know happy with the response. So what he did, like he is publishing that article. So he gave it to me, that a manuscript. So I compiled some data there, and at the moment that is studies under the publication process.
And this was with a monotherapy.
Absolutely
Right.
monotherapy. Nothing
Right.
else was given here.
In any experiences in melanoma, because
Uh,
we have little to do with melanoma in the Indian setting.
Yeah, so in an Indian setting, we don't have experience with melanoma, but we have experience with melanoma in an American setting. Okay, so before the lung cancer, I mean, all the studies which Dr. Amit demonstrated were done under the protocol and INDs approved by US FDA.
Okay.
So the first trigger, the first IND which we filed with the US FDA was for a melanoma. So there is a group in US who were trying to do desperately for various products. They are evaluating in a very aggressive model of melanoma. In the animal model, the melanoma metastasis to the lung in less than 3 to 5 days, and all animals die within 2 weeks. So this is so aggressive model. In that model, they evaluated Mycidac-C, and then they came out that this is the only product they have evaluated so far which has shown some promise. So metastasis to the lung was delayed, and on the top of it, animals survived from 2 weeks to 3 weeks. So they survived longer. So that prompted them to go to the human clinical studies. And in the human clinical studies, out of the 12 patients who were evaluated as a monotherapy, this is again as a monotherapy, out of 12 patients, 3 patients had no evidence of a disease at the end of treatment. Okay, so if there was a particular way it was given because they were metastatic melanoma. So the Mycidac-C was given twice a week for 2 months, then evaluation, and those who responded was given the second cycle. And when the disease became stable and then there was no evidence of active disease, uh, the surgeon resected the whole melanoma, and then when they resected, they found that all cells were apoptotic. But just to make sure that they resected, so out of 3, 2 were dissected, and they remained disease-free till last follow-up. So this is a melanoma story.
Okay. Okay. Okay.
And this product, I mean, if you have a cutaneous melanoma, this product can be injected intralesionally also. So it's not necessary that you have to give intradermal or intravenous.
Okay.
You can give intralesionally also.
Okay. 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 Thank you, Mr. Amit and Mr. Kemar. Thank you.
Sir, I would like to thank you.
Yeah. I
Yes.
believe like our vertical head, Mr. Rajiv, is also there. Rajiv, are you here? Rajiv?
Yes, Dr. Amit, very good evening.
Yeah, good evening. We were waiting for you, actually.
Yes, actually, I was into a different meeting.
No
Okay.
problem.
Then I logged in from my mobile. I'm driving currently in the car. So I heard everything you said, and then Dr. Kamar as usual. It was amazing once again. So, sir, very good evening once again. And I hope the question answer. And then last, what we have said, Mycidac-C, something, sir, we missed out as the marketeer to really reach out to eminent doctors like you in time. However,
Okay.
sir, as soon as I joined over here, and then we decide, okay, let's start discussing about this product, very product, and then I happy to share with you. Other than this all information, sir, it is being taken up by Dr. Kumar Pravash in Tata. So it is under the protocol of the lung cancer treatment, and then we are getting approximately 10 to 15 patients every week now.
Okay.
It is also been approved in TNMSC. So Dr. Prem Kumar Devdas in TNMSC is using extensively today. It's also approved in GCRI. It's also approved in Rajkot Cancer Society. Now it is also approved in Medanta Hospital. Dr. Ashok Vaid is using it now, this very product. So, and then multiple other centers. So, and then the responsibility lies on us that how we take up this product and we are trying to shape. I heard you saying in between asking about the PMS. Sir, we are running even currently. Also, we are running the PMS on Mycidac-C. We have the web portal created so that there is no data problem that or malafide intention using. So what we have done, we have done online CRF. The username and password we provide to the customers, doctors directly, and we have the team members who actually come across and then punch in the entire data retrospectively and then prospectively whatever you do. We generate that data and then we are committed to publish. Just now, what Dr. Amit has concluded, sir, we are publishing that data also, that complete response rate, monotherapy Mycidac-C. A very encouraging response coming in, sir, from all the doctors across India, like Dr. Eminent, Dr. Yu, Dr. Dattatreya in Hyderabad at Omega is using.
Okay.
So, sir, so that is what is. So, just trying to build up the confidence. TMC Kolkata. So there also, Dr. Deepak Dabkara, medical oncologist. So these are the doctors that started using it. We are just trying to build this confidence. And what we are looking at, Dr. Bowman Davar in Bombay now is also one doctor who started. So all these doctors, what we are trying to develop is that, sir, checkpoint inhibitor, PD1, PDL1 today, checkpoint inhibitors is the one cycle cost itself is around 2.5 lakh rupees. And this product, which has been invented, Dr. Khamar himself, the principal scientist available, sir, here. I think he is the best person to speak all about it. But whatever I have learned, that's 2.5 lakh rupees versus 4,000 rupees only one injection, and then total cost of therapy, sir, 45,000 rupees. So today, when I was into multiple levels of meetings are attended, wherein hardly 2 to 3% patient population, which also into either the very upper rich class of person or reimbursement from the government setup, are able to get these kind of benefits of checkpoint inhibitors in lung cancer. 3 to 4 months survival advantage in these conditions with Mycidac-C. I think, sir, it is worth giving a try for these lung cancer patients. So I urge you and request you, if you please take up this, would be really kind of you, and then which will pass on benefit to all these patients. And there are large number of patients are actually waiting for any kind of a therapy we provided.
Right.
So that is very humble submission to you, sir.
Right.
And we reach out to you once again. My team is there. We'll hand over the IV protocol document which we have received BCI approval. And there are most of the doctors today started using IV, though there are many using intradermal also. And as Dr. Khamar already mentioned, the pre-medication of dexamethasone base before use IV, it is absolutely safe drug to be used. And happy to serve you and connect you and wherever you feel like, sir.
Right.
Sir, just few minutes, sir. Actually, I think, sir, Dr. Rajesh, sir, actually, when we had discussion with Raghunath, sir, during our Nudoxa meet, I think Rajesh, sir, was present. You were there and who had supported very well.
Coimbatore.
And no, sir, Nizams. Hyderabad with Dr. Sadashiv.
Hyderabad. Yes.
And Rajesh, sir, has got a lot of presentations during, I can say from 2012 to 2014, sir, has got lot of presentation. His work on NSCLC was also quite, remarkable. With Raghunath Rao, sir, you can imagine, sir. Sir now serving at Nagarjuna Hospital, Vijayawada, and who has got a very good patient pool also, sir. And we had done a meeting in 2016 as well as in Vijayawada, where Rajesh, sir, has taken the lead and helped us a lot over there.
I distinctly remember, sir. Now, yes. So that's really kind of you. Reconnect you once again.
Yeah.
Trust me, we are trying to build up multiple things around over it. As more melanoma, bladder cancer, sir. The intrathecal BCG insertion versus you use this IV or a shot or maybe some intradermal. So it's much better and very promising result coming out. So give it a try, sir. Let's see, and whatever best possible we can help assist you. I would be more than happy to assist you, sir, better.
Definitely. I have one question for Dr. Kemar.
Yes, sir.
Yeah. Do you have any feedback from the doctors when this is used in the second or later lines, not in the first line setting, later lines?
In NSCLC?
Yes.
No, we have not tried that. At least I am not aware. Doctors may have tried it, but we have not tried it because it gives good results in first line. Why go for a second line? See, everybody was after us when we started that. why you are venturing into first line?
Okay.
Okay, so including US FDA. I mean, if I ask you what they are told me, they said you have extra money to burn. You are venturing into this. I said time will tell whether I have extra money or appropriate money.
Right. Okay.
But
Sir,
since you are
takes.
hold on. Since
Yeah.
you are an oncologist, so in a bladder cancer, while what they are saying is for a superficial bladder cancer, which are responding and non-responding to BCG. But more than that, when you have an advanced bladder cancer, you don't have a choice of giving BCG, correct?
Yes.
So even in those patients, this product has given complete response. So I mean, I have my own uncle who
Okay.
was left with the palliative therapy, and he approached me, can you do something? So he was given 20 GY radiation, and I gave him Mycidac-C every fortnight. And after 2 months, it was difficult to identify where the tumor is. And originally tumor was 9 centimeter big in the bladder. Okay.
Yeah.
Within 2 months, it melted. And then he survived disease-free for 2 years.
Okay. Nice.
He
Yes.
died of something else, being aged person, but he was disease-free till end for 2 years. So even if you want to try in those metastatic diseases or advanced diseases, if it is localized to one area, you can use low dose radiotherapy like 20 GY palliative therapy and add on the top of it, and it should add value to it.
Okay.
Now, in relation to the checkpoint inhibitor, I mean, checkpoint inhibitors are passive therapy, while this is active immunotherapy, and that's the reason the side effects are not there, because this boosts immunity of your own body. And while boosting immunity of your own body, I'm sure you know that there's always a balance between suppression and stimulation. So while boosting immunity of your own, it also suppresses immunosuppressive part of the immunity. So it has a double role. So I mean, checkpoint inhibitor works by reducing PD-1. So this also reduces PD-1 by half. It also reduces Tregs, immunosuppressive cells, and so it is a dual action, active immunotherapy. And because it is active, it does not have a side effect because body will control whatever it wants.
Okay. Right. Thank you.
Thanks, Dr. Rajesh. Thank you so much.
Right.
Thanks for giving time for the session.
Right.
Yeah. Good night.
Right. Good night.
Good night, sir.
Thank you, Dr. So nice of you
राजीव आपका नेटवर्क गड़बड़ लगता है.
to have you.
Hello.
Thank you, Dr.
Thank you, Dr. Kamar. Thank you, Dr. Amit. Thank you, Rajiv sir.
Chali. Okay.
Good night, sir. Good night.
Good night, sir. Thanks a lot. Bye, sir.
So off the line now, what